having our next topic for the session is traumatic brain injury by Dr. D.K. Singh, Professor of Anesthesiology and Director of the Trauma Center, BHU. Pre-hospital.
Sorry for this announcement. Actually, sir is, for me is a pleasure. Sir is here, my teacher at BHU, and that time sir was also head of department. And topic sir today sir is taking how safely will transport the patient from the trauma site to the hospital. Traumatic brain injury next part that will taken care by Dr. Devasis sir. So I'd like to call sir on this.
A very good evening.
Thank you, Chair.
Today we have a very important topic of trauma, because trauma and road traffic accident is a major portion of hospital admission these days, and pre-hospital care is one of the most important aspects these days for trauma centers. So we have a very excellent speaker today, Professor D.K. Singh, who was earlier the professor and head of the Department of Anesthesiology at BHU and also at IMS Bhopal. Now he is the professor and director of the upcoming trauma center at BHU. So Dr. D.K. Singh, please.
Thank you, Chairperson. My thanks to organizer, especially Dr. Kishore. When he called me then that you have to come Patna, because I like Patna, I like visiting this place because I have a lot of relatives here. So I immediately agreed to visit. But at the same time, when I was traveling from Varanasi to Patna by road, I was thinking that I did a wrong way to reach Patna. I could have taken the train, but the train was late. And that is how on the way I saw many people traveling on the rooftop of the jeeps and buses. This is the way we are traveling in UP and Bihar. If you go to Aligarh area, you will find a special kind of, that is known as that area, Jugaad vehicle. They run the, like a jeep type vehicle through a generator engine. And if we are traveling like this, then definitely we will have a more trauma in the UP and Bihar. So polytrauma or trauma is the side effect of development. If you are developing, then you have to have this side effect, because roads, increasing speeds, lot number of vehicles, and there is a tendency to drive in a speed without any safety devices. So there will be more trauma, especially in UP and Bihar. So I bring greeting from the Varanasi University. This is aerial view of the BHU campus. I think you all must have visited Varanasi. This is a closed city, and the city is known as City of Temple. We have one good temple in the BHU campus, but the whole city is not this green as the BHU campus. The whole city is very, very crowded. No change even after the Modi era. So this is the trauma and emergency block of the IMS Bhopal. I was there as a head of department in trauma and emergency medicine for some time, but I was called back to the BHU. This is the BHU Trauma Center. The Government of India through Ministry of Health has chosen Varanasi, maybe because we had many bomb blasts in Varanasi. First Sankat Mochan Mandir bomb blast, Sramjeevi bomb blast, Ganga Ghat bomb blast, courtroom bomb blast. There were many bomb blasts in within few years. That is how I think the Government of India decided to construct a trauma center. But this is again traumatized by these political issues between the Health Ministry and HRD. So I will not detail. I still waiting to be inaugurated by the Prime Minister. India leads, as I said with the earlier remark, India leads world in the road deaths. We have a lot number of deaths. This is UP, this is other state, but certainly it is underreported. I think it may be 1/5 or less than that, which are really being reported in the crime database of the state government. And most of them in the rural area, they are dying and they are not reported in the literatures, are reported to the government. So this number is also very less. Even with this less reporting, we are at the higher side of having the trauma cases. So there are a few things which were recommended earlier. Stay and play, or scoop and run. It goes with the word. At the site of the accident, go there and start treatment there. And whether to scoop and run, nothing was reported after a few years, 5 years experience. They reported that even if you stay and play, it is not helping the patient. And stay and, there is a good case for stay and play. You all know that this lady, Diana, and the accident was there and a team was sent on scene and they tried to treat her on the side, but the result was she died. Again, scoop and run, this famous Ronald Reagan case, and they took immediately to the hospital without providing any help on the way, and patient died. So aim is to get the right patient to the right place in the right amount of time and provide critical care during transit. Here we can use the technology. I will talk little later about it. So objective of my talk is initial management, to summarize basic care of undertaken during the transport, to summarize various techniques of effective communication between pre-hospital care providers and concerned emergency department, provide advice on communication on specific situations, brief note into trauma scoring. Assessment. You all know that primary survey and resuscitation done simultaneously. It's not that you wait and do the survey and then you decide. It has to be done together. And there are many courses, ATLS, CTLS courses, and they train you how to do these two things together. And identify the problem, you address it before you move on. We are all know that ABCDE. So ABCDE is good for every place. So as I talked about these courses, there are many institutions running such type of courses, and it is very useful to do all these certification courses. So polytrauma, the chain of survival is early access to the trauma victim, early resuscitation, early transport, early to hospital assessment and stabilization, and early definitive care. Everything should be early, should not be late. So this needs a good teamwork. Single person cannot do everything, and you have to have a teamwork. And that is how this trauma centers has been given the posts and everything, so that every doctors, means those who are required for the trauma center, the management of the trauma victim, they should be physically present at the trauma center with the all help of modern technology. Rapid assessment, we all require this such kind of teamwork. Rapid assessment of the physiology and anatomy, and simultaneously you have to resuscitate. For that you need a team. There is certain different means from adult patient to pediatric, some points you have to keep in mind. Same priority and approach, need for different amounts of fluid and medication, need for different size of equipment, and in some centers they practice because they have got a designated covered for the particular size of patient, so that you need not to go and check, and you just open that covered and you will find everything very useful for that particular size of the patient, a particular age of the patient. Pregnant women, almost everything is the same, but you have to consider about the anatomic and physiological changes, and potentially two patient, not one. In elderly patient, there is maybe comorbid conditions, heart disease, diabetes, lung disease, and multiple medication may be taking patient, increased risk of death for any given injury compared to the young patient. So I have to very, very good and very, very quick to these patients. Again, coming to the A, with this, because when we check for the A, that is airway, in the trauma patient you have to see for this cervical spine protection. Does this patient have adequate airway and they can be protected? With the airway you have to care about the cervical spine. We get such kind of patient, then there is likely to have a chance of having the cervical spine injury. So how to assess? Again, here is a scope of look for facial trauma, foreign body, listen and feel. If the patient is talking to you, that is the one condition where you can get a little more time to assess for the patient. Management of the airway, you all know how to manage the airways, not to talk in details about it. This is a very common scene. In every hospital, we transport the patient like this. We see at the site of injury patient like this. This is a picture. You see, it is very difficult to triage or to decide which patient needs first. And this is the way we transport this patient like आलू का बोरा. उसी तरह से भर करके भेज देते हैं अस्पताल में जाएं. Site of accident, suppose the Danapur is the site of accident, and the medical officer in the Danapur dispensary will load every patient, whether it is required to send it to PMCH or to higher center or not. He will send every patient by using this kind of transport system. So this is I think the real picture in India. So cervical spine, where you have to be like very careful. If this is a multi-system trauma, altered level of consciousness, then you have to think that if the patient might be having injury above the clavicle. Collar, sandbag backward, maintain inline stabilization during all procedures. Because at the site you don't have the X-ray system and you don't have other facility to decide whether the patient is not having. These are the few equipments which helps you at the site of in the stabilization of the neck. Just to a case scenario, 13-year male suffers from gunshot injury. Emergency medical system called. On arrival, airway was intact. Breathing was decreased, both sides on the right side, bilateral side and right side. Circulation, heart rate was 110. Breath sound on the right side was decreased. Circulation 100, HR was 110. Strong radial pulse was there. Disability GCS score was 15. Exposure, bullet injury, 5th intercostal left parasternal side, and bullet injury right 8th intercostal space posterior axillary line. What to do? During transport, high flow oxygen, place on gurney, transport initiated 1 minute at the scene site, 2 IV line placed in the route. So when you take the patient in the ambulance, you start give the IV line, because that time can be utilized. And in the emergency evaluation, patient blood pressure was 110 by 80, precardial ultrasound positive for fluid. Operation room finding was blood in pericardium, wound to interior right ventricle near right coronary artery repaired, wound to lateral right atrium repaired, normal transesophageal echocardiogram, it was done in the operation theatre, right lung repaired, bleeding diaphragmatic vessel ligated. These are the few pictures of the during intraoperative. So, just to describe that the patient has reached to the right place and the right time, the patient can be easily saved with this, even with this type of injury. So right patient at the right place with the right amount of time, it is very, very important for the trauma patient. Coming to the point number B, like breathing and ventilation. Patient airway does not equal adequate ventilation. Even the patient airway, there is no problem, but you have to see the ventilation of the patient, because ventilation is important for this gas exchange, oxygen in and CO2 out. But problem is that this is the picture of when we received the patient of the SRAM GV bomb blast case. All were burning and mixed injury and high velocity sound injury was there, and they came like this. It is very difficult to see whether the patient is breathing or not breathing. So again, how to do? Look, listen and feel. You all know about how to do look, listen and feel about the breathing system, chest, and listen about the auscultation of the absent or decreased breath sound, feel percussions for dullness and hyperresonance. Identify tension pneumothorax. Even if you are planning, when patient needed CPR, in the tension pneumothorax it will not be very effective. Open pneumothorax and flail chest with a pulmonary contusion. You have to decide, we see in very quick way to identify this. Fast, focused assessment of sonography for trauma. This is a good things which is coming, I think every institution or every anesthesiologist or every trauma specialist should know how to do this fast. because it within a very short time you just find out means very, very important things by just applying a probe over the patient chest or abdomen. Management of breathing, you all know how to manage breathing. If there is a problem, nasal cannula, bag mask, intubation, pulse oximetry, needle or tracheostomy. Just to give a case scenario, 55-year male, means there was a stab injury, airway intact, breathing 24, equal breath sound, circulation was 50, heart rate was 58, blood pressure 114/68, GCS was 14, exposure, no other injuries. During the transport, high flow oxygen, pulse oximetry initiated, initiate rapid transport to the trauma center and initiate IV fluid therapy en route. This is operative picture and patient was saved by just ligating few things. Circulation and hemorrhage. Coming to see, this is most important predominant cause for the post-injury death that are preventable in hospital setting. Hypotension may be due to the hypovolemia, blood loss until proven otherwise, because in spinal shock you also get the hypotension. Assessment of circulation, quickly you can assess the circulation level by level of consciousness, skin color, pulse, rate and quality and blood pressure. Identify massive pneumothorax, cardiac tamponade. If you are capable of doing fast, you can identify in a very quick way all these problems. Massive pneumothorax, cardiac tamponade, internal hemorrhage and external hemorrhage. If there is external hemorrhage, apply direct pressure, or there are many other things which can be done to stop the bleeding. Management of circulation, tube bag means large bore IV lines should be there. Ringer lactate, wide open, warm, 30 normal temperature fluid, 1 to 2 liter of the warm IV fluid in the way. Coming to a case scenario, 29-year male fishing a small boat at 1 AM, boat run over by speedboat. At the site, it was found that airway intact, breathing shallow, 34 per minute, equal, circulation, no radial pulse, systolic blood pressure was low, 80, significant hemorrhage from the lower extremity. GCS score was 13, E4, V4, M5, exposes no injury to torso and upper area. So this was the picture of the injury. High flow oxygen and pulse oximetry during transport time. Tourniquet placed on the bilateral thigh. Transport initiated, intravenous resuscitation began en route. So there are some pitfalls in the assessment of the circulation. In elderly patient, limited ability to increase the heart rate, because BP often has a little correlation with the cardiac, maybe on medication. Children's means there is some things which consider if the patient is elderly patient or pediatric patient in assessing the circulation. Again, if you have assessed all these things, then D, coming to disability of the neurological evaluation, GCS scoring, bilateral pupil size and reaction, any lateralizing sign, early lateralizing sign, you have to check it, and objective to establish the baseline to allow the detection of the change within the time. You may have a patient, because this is stab injury in the skull, so you have to check for the neurological sign. Which patient are classification of the patient which can be classified as major trauma or minor trauma. Major trauma patient, there is a simple way of the 3 parameters: systolic blood pressure less than 85, motor components of Glasgow Coma scale less than 5, penetrating trauma of head, neck and trunk. You all this mark as a major trauma, and you try to do the best thing by transferring the patient as early as possible to a better center. In disability, in some, as I said, spinal shock or neurological deterioration can occur rapidly in a epidural lucid period, talk and die. Frequent re-evaluation of the patient if they are thinking that patient is deteriorating neurologically. Exposure to environment, maintain temperature, completely undressed. Sometimes you get the patient with completely undressed. Prevent hypothermia. You may feel hot, but the patient is naked and metal table, blanket, warps, IV. These are the few simple things we ignore. Sometimes we transfer the patient on the metal table. We forget even to place a seat. That is causing hypothermia to the patient, which causes many problems. Always inspect the back. Whenever you get a patient, and whenever you should know the mode of injury, then must see the back of the patient. Sometimes we forget to see the back of the patient. Adjunct to the primary survey, F means coming to the ABCD. F is full set of vital signs focused adjunct. Blood pressure may be poor, measure for actual tissue perfusion, pulse oximetry. These are the few things which should be done. Documentation is very, very important. We always fail in documenting the situation because of we are always in the chart and we are not in habit of writing the things. Transport is very important for the transportation of the trauma patient to the proper site. Patient destination based upon the medical appropriateness. In India, we always say that it is your luck in which city you are getting sick, in which city you are getting injured, which hospital you are going first, and who is the doctor there who is attending you the first. It is just your luck. If you are having a good chance to have an accident in a good city and good trauma center, you reach to good trauma and the good doctor is there, otherwise it is your. So you have to take care about this golden period. For critically injured patient, initiate transport to the closest appropriate facility within 10 minutes of arrival at the scene. Don't waste time at the site of your injury. Destination is trauma center. Immediately available, because the government of India has now decided as a policy, whenever they are going to construct the highways, they are going to incorporate this trauma center into the cost of the highways. So that after every 200 kilometers there will be a good trauma center, and nearby medical college will be given the responsibility to run these trauma centers. So a trauma center should have a specialized surgeon, physician, nurses, allied health personnel, and resuscitation and life support equipments. Triage. Triage means sorting of the multiple patients, and that is always based on the ABC. It's a good joke. Bring the worst, make you first. If the patient is very serious and the patient should be transported immediately to the operation theatre so that you can do everything there immediately. Goal of the pre-hospital triage: identify the trauma patient and that will need the high level of trauma care. Bring the trauma patient to the particular hospital that will be the most capable of carrying the patient. Actually, what happens in the normal, as I said, every patient will be transported to a particular hospital. Here, but what happens, like suppose a PMCH, they don't have that kind of vacant bed. Suppose if there is 50 victims coming to the hospital in casualty, there will be no 50 beds vacant at that time in the hospital. So they, on the side, they should decide which is most important, like they need to go to PMCH or they need to go to lower hospital. So from the site of injury, in site of accident, this has to be decided. Otherwise, there will be certain load in the PMCH or major hospital, major trauma center, and that will hamper the care of the actual patient, those who can be helped in that better trauma center. Over triage, transporting minimally injury trauma patient to the trauma centers. Over triage is up to 50% considered acceptable. Often a financial and resource issue. Under triage, failure to transport major trauma patient to trauma center. Under triage, rate of 5 to 10% considered unavoidable and associated with the over triage rate of 30 to 50%. Often a political issue. Sometimes if you the patient is rich or the accident is by Mercedes, they will send the air ambulance. If the patient is from the other country, they will send air ambulance. Otherwise, nothing is for the poor people. Even the local police thana will not even provide the tractor to that patient to reach to the hospital. There are many scales which is in practice. Vital signs, and this is recommended by ACS, American College of Surgeons, pre-hospital criteria, 2 referral to a trauma center. Glasgow scale less than 13, respiratory rate less than 10 or more than 29, pediatric trauma score less than 9, systolic blood pressure less than 90, and revised trauma score. There are many scores and not much of them are in practice. But certainly, if you are having a patient like anatomical basis, flail chest, pelvic fracture, 2 or more proximal long bone fracture, burn 10% of the total body surface area with inhalational injury. Penetrating injury in the head, neck, torso and proximal limbs, limb paralysis. If there is a neurological deficit, then you should send the patient to trauma center. Proximal limb amputations, because limbs are also very important. Mechanism of injury is also criteria for sending the patient to a better center. If the ejection from vehicle, death of another occupant of the vehicle, pedestrian thrown or run over by vehicle, displacement of front axle more than 50 centimeter, intrusion into passenger compartment less than 30 centimeter, more than 30 centimeters, fall from more than 6 meter height, vehicle roll over, motorcycle crash more than 32 kilometer per hour with separation of the rider and bike. These are the victims which should be seen properly and sent to the trauma center. Suspected major trauma center pre-existing condition, if the age is less than 5 or more than 55, if the patient is also having as a comorbid condition, cardiac disease, respiratory disease, pregnancy, and if the patient is anticoagulant and bleeding disorder, and with the injury, if the burn is there, then we should refer the cases to the good trauma centers. Communication during transport. We have developed a lot in communication system because of 3G, 4G and 2G, and we have a mobile system and smartphone. These are very helpful tools in managing these trauma patients. And now with the telemedicine, from one center you can control, from Patna, if you are having a telemedicine center and you have adopted few roads or highways under your control, and the patient is moving from even maybe 30-40 kilometers, you can advise the patient because the personnel is there and they are moving with the smartphone. So you can see the picture of the injury, you can advise on-site treatment so that it will be given immediately, because the paramedical staff, if there is trained paramedical staff, they can do it. So communication is very important. Allow early warning to the emergency room, also to prepare incoming patient. Suddenly you will receive a call that patient are reaching to you, 50 patients are reaching to you within 30 minutes. So if you are even getting the 30 minutes, you can prepare your hospital, you can move some of the patient from the casualty area to get some vacant beds. You can order IV stands, drip sets and other dressing materials. You can pool the nursing staff and other things, because when we had this Sankat Mochan bomb blast, that time we were having this nursing capping ceremony. At one place there were 300 nurses. So immediately called every nurses to the hospital. Just to leave that function and come to the hospital, because the capping ceremony was going on. So they all were in the dress, and every patient is allotted a nurse. So the society and media appreciated that, because every patient is now having one attendant as a nurse. So we are lucky, because that time there was function was going on and they all were together. So we have to develop such kind of system. Suppose there is an alarm system in the nursing hostel. If this alarm goes on, then everybody should rush to the hospital. You all know the importance of communication, because communication is very, even as a doctor, you have to be a very good communicator. And in the trauma management, communication skill is also very, very important, because to manage everything, not from administrative point of view to clinical side also. This information, recommendation should be given to the hospital prior leaving from the scene or at initiation of the transport, especially if transport time is less than 5 to 10 minutes. However, should not be delay, extend or means you have to pass this information to a nearby hospital that such and such number of patient is being on way to your hospital. Numbers of victim, age, gender if possible, identify unit of transport and time of arrival, because this is all the information. It helps you in preparation for receiving of this kind of patients. determine how many patient his hospital can accept, especially the emergency capacity क्या है उस hospital की. Call intensive care unit to determine number of ICU beds available. Suppose if the ICU bed is full and your ventilator is not free, you don't accept that you immediately can allow a patient dead and you can take the ventilator out of that patient. You have to be prepared with that, because certainly you can't have a large number of ventilator free in your hospital. So if you are receiving a patient, you should know that such and such number of patient is coming, and we have to be prepared with the ventilators also. Hospital personnel notification, radiologists, CTs, respiratory therapists, blood bank, security. Blood bank is also very important. Certainly they have to do a lot of works to issue or match the blood samples, because you are having a large number of blood samples sent to the blood bank immediately. Security staff is also very important. In these days, because these are bomb blast incidents, the recommendation is that after you are getting a news that such and such bomb blast has occurred in the nearby, first you just check the hospital, because sometimes the bomb is planted in the hospital, as it happened in Ahmedabad. When the doctors were on the way, there was a bomb blast in that container and 3 doctors died in Ahmedabad. So sanitation of the hospital is very important before you receive the patient. Specific equipment means airway, endotracheal tube, laryngoscope, sedatives, intravenous bags, blood tubes, chest tubes, negative blood units. In the blood bank you have to check all these things and try to get as much as possible number of things, because if you know the number, then it will be easy for you to arrange all these things. We can't think of shifting the patient by way of helicopter, because every trauma center was designed to have a helicopter pad, but ultimately they constructed the helipad, but there is no helicopter. This is the data from Trauma Center AIMS Delhi, and what they found, you have a 25% lower risk of death at 1 year in the trauma center. If the patient has reached to the trauma center, the chance of saving the patient is 75%. So if you are not reaching the taking the patient to trauma center, they have the maximum chance to die. Means they have got a more chance to die. And if they are reaching to a trauma center, they have got 25% lower risk of the trauma center. This is the data from the AIMS JPN Trauma Center in 2006. There are many booklets published for the information, for knowledge, for everybody, pre-hospital transport, and these are the good books, and which can. Ambulances has improved. Initial, when you started the medical history, we had ambulances like this, but now we have good ambulances, and with the all communication facility, with all technology, ventilator fitted, means it's a ICU setup type ventilator, so the chance of, if you are having this type kind of ventilators, chance of means treating and saving the patient of trauma victim is more. If you are not doing good things, then the patient might reach here to the Madhikadika Ghata Banaras. So to reduce the rush, you have to manage the trauma patient very nicely. Thank you very much.
Thank you, sir, for your nice elaborate talk. Your talk reflects the experience you have got in trauma management. But one thing I would like to comment.
Even then, we have not learned many, even after having the experience, because in the government setup, there are many limitations, and in the private sector, there are again the different limitations. We have not learned even after the many bomb blasts or many.
Trauma management is such an area. You can talk weeks together. It will not end. But the only thing I will
I think SGPGI means Dr. Baronia is here.
Yeah.
All the trauma center in trauma stage now.
Yes,
they are not having the good number of staff allocated. They are not having the good number of fund allocated. Even the best thing is that government has started thinking out of it.
Basically, what we can do, in the pre-hospital trauma management. Change the attitude. That is the one thing that saves a lot of time. Not only the attitude of the doctors, but the persons in the ambulance, emergency medical technicians, the onlookers, the drivers, the police, which transports the patients. So unless you get involved, patient cannot get care which he should get in limited time he has got. So the change in the attitude, that can only be achieved by training and more training. That is the only answer. Unless you change the attitude, we cannot achieve much, even with all the infrastructure and doctors available.
Dr. Ajit, I did not talk about those political issues. When we had, as I told you, the bomb blast and patient in the hospital, this VIP visit was the most problematic things. And when they were visiting the hospital, they were visiting the huge number of followers, and they will go to the patient side, they will get their photograph done, they will issue a check. Even some of the time, some patients not involved in the trauma on that side, they will try to get a hospital bed so that they can receive the ex gratia payment. Some will try to be declared themselves dead by just giving their false name and false address. This is very, it's not only the management of the trauma, but the medical management. Medical management, I think, is not a problem in the big setup. The social and political management is a very big problem.
Thank you, sir.
Thank you.
Now this is time for question session. Since I have learned a lot from the Dr. D.K. Singh sir at BHU during my post-graduation period, before asking, I just want to know one thing, sir. At the site of trauma, before shifting, if you have all everything are available like crystalloid, colloid and blood, from which fluid you should resuscitate first? If there are a lot of confusion.
The recent recommendation is there for everywhere. It's not for only one site or accident site. Normal saline is the best fluid and available. It should be used, but certainly there was like a Schumacher study which came, I think, 5-10 years back. Means hyperperfusion. Now hyperperfusion is not recommended. If you are getting a pulse, radial pulse, not to transfuse much of the fluid, just keep an IV line. This is the new recommendation.
But
so sometimes the patient bleeds more if you the hyper means like supranormal infusion term बीच में दिया गया था to get a good cardiac output. There was a study and there was a good recommendation about this supranormal means the infusion of the fluid, but now it is not recommended.
For the trauma, will you agree for the ATLS recommendation? That is, we have already shown the protocol of ATLS. They have recommended Ringer's lactate in at least in a polytrauma case, severe trauma case, 2 liters of Ringer's lactate immediately for the resuscitation.
No. First, which I said, if you are getting a good pulse, good radial or femoral pulse, femoral not if you are getting a good radial pulse, not to transfuse large volume of the fluid. That is very good recommendation. If you are not getting that, transfuse that Ringer lactate or normal saline, whatever they have is available.
I do agree, sir, because if the patient is in shock, the Ringer lactate could be better. But if the patient, you are getting a palpable pulse and blood pressure, which is acceptable, we can go for normal saline.
That's why I said if you are getting a pulse, not to rush with the fluid. Not to talk about now the supranormal infusion and supranormal cardiac output is not recommended now.
Thank you very much.
Thank you.
Very nice presentation. You almost covered the protocol of trauma.